Can you see my presentation?
Yes.
Okay.
All right, and I believe we are live. Assalamu alaikum, everyone. Thank you for attending. Ramadan Mubarak to all, and welcome to our Health Literacy webinar. My name is Noor Al-Huda Al-Hashim, the head of the NICC Literacy Series, and I will be moderating our important topic today. Over the next hour, our two speakers will be sharing their expertise on diabetes and metabolism. We will dedicate the last 20 minutes of our session to Q&A, so please share your questions in the Q&A box. Ramadan, the month of fasting for Muslims, comes once a lunar year and brings so many opportunities and challenges to those who observe it. It is also unique this year. It has without a doubt forced us to think of our health as a continuum and brought the power of the unseen to our sight. We're excited to host a very much needed topic about the impact of fasting on our bodies for both kids and adults. Today, we have Dr. Mamilly and Dr. Ghalib as our guest speakers. We're so thankful that they're sharing their time and expertise with us. I will begin by introducing Dr. Mamilly, who will begin her talk first. Dr. Mamilly is a pediatric endocrinologist at Nationwide Children's Hospital. She was born in Aleppo, Syria, and graduated medical school from Aleppo University. She graduated pediatric residency from Children's Hospital of New Orleans and worked as a general pediatrician for 3 years. She then trained in pediatric endocrinology and diabetes in Women and Children's Hospital in Buffalo, New York. She has worked at Nationwide Children's Hospital for the last 2 years and has focused on pediatric obesity, pediatric diabetes, and early detection of its complications, growth disorders, and puberty disorders. Dr. Mamilly, thank you so much for joining us. We're excited to have you, and you may begin.
Thank you, Noor. Assalamu alaikum wa rahmatullah. It's my privilege to have been invited to participate in this webinar. Inshallah, I'm going to go over issues related to Ramadan and metabolic health and type 1 diabetes. And so as an overview, my goal is to go over some metabolic changes that happen in our bodies when we fast, the specifics of fasting in persons with diabetes, and particularly I'm going to be talking about type 1 diabetes and how to safely fast and when to break fast and those kinds of questions. And so to begin with the size of the problem or the size of the matter here, the Muslim population has been growing, mashallah, continuously. We, as Muslim population, comprise about a little bit less than a quarter of the world's population, about 1.8 billion Muslims worldwide, mashallah, from the last thing I read. Knowing this fact and knowing how common diabetes is in adults, plus the studies that show us how many Muslims usually elect to fast even if they have diabetes. It has been estimated that about 50 million Muslims worldwide fast while having diabetes, and this number actually is from several years ago, so it's expected to be a lot higher now. And so before I dive into diabetes and fasting and what issues are associated with that, I wanted to reiterate the health benefits of fasting. Fasting is this big change in our lifestyle and our way of eating that is associated in the healthy individual and most people associated with very good benefits. Our bodies usually during this month transition from burning sugar and carbohydrates into a fat burning mode. They go through a process which can result in weight loss. However, we got to be careful in saying weight loss because a lot of the studies showed that not all people that fast lose weight. Depends on how much caloric consumption they do during that month, the month of Ramadan. Fasting is associated with reduction in cholesterol and LDL cholesterol, which is very tightly linked to cardiovascular health. It's associated with a detoxification process, and there are studies that show reduction in free radicals during fasting. There are many, many studies looking at differences in the way our immune systems work during this month, and there is evidence of decrease during the holy month of Ramadan. And so fasting is not unique for Islam. There are various fasting practices that are included in Christianity, Judaism, and Hinduism. Also, intermittent fasting has been, for the last couple of decades, a medically endorsed form of dieting, and that has been studied actually a lot heavier than religious fasting has. There are various forms of this fasting. Some individuals do it alternate days, some 2 days a week, or even daily intermittent fasting. Now, this form of fasting has been heavily studied and showed benefits in relation to metabolism, so the way our bodies handle insulin and glucose, benefits to heart health, brain health, and even immune system. But however, there are a couple of things here to mention about intermittent fasting. One is that if with intermittent fasting, water intake is allowed. And so that's a very important difference from Ramadan fasting. And then the other is that usually with these kinds of diets, there is overall reduction in the total calories consumed by the individual, and usually they're associated with weight loss. So some of those benefits that you see might be related to weight loss associated with intermittent fasting. And so why do our bodies work differently in Ramadan? There are usually drastic changes that happen in Ramadan compared to the weeks before and the weeks after. Our meal timing changes. We go from eating 3 or 4 meals a day that are scattered throughout the day to eating 2 major meals that are usually late at night and very early in the morning. The meal size and composition changes. So we eat usually in iftar a higher amount of calories as compared to, say, lunch and dinner on a non-Ramadan day. Our sleep schedules change, and studies have shown that people in general sleep less in Ramadan than they do in, outside of Ramadan. And our sleep duration and quality of sleep changes too. So people spend less time in REM sleep and more time in non-REM sleep. Sleep is usually intermittent in Ramadan. And this all is associated with changes in our hormonal profile, so or if biological clock, if you will, meaning that our hormones like cortisol that have a peak secretion in the morning, usually and are lower at night. This cycle gets interrupted or gets shifted during Ramadan, and this affects our body's way of handling carbohydrates and insulin, among other hormones. And so what happens in our bodies when we fast? So we're going to go through a day of fasting to see how our bodies handle this interruption of calories in suhoor happening. So initially, after suhoor, we have carbohydrate intake. So our bodies run on the sugar provided by that meal. Once our body runs out of the fuel provided by the meal, then our sugars tend to go down, and because there's no more glucose to be consumed and to be used, and our insulin should shut off in a healthy individual. The insulin shutting off allows the liver to put out its glucose storage, which is what's called glycogen store from the liver. So the liver puts out whatever energy it has stored in order to provide fuel for the body. This usually provides fuel for about 12 hours in an adult on average. And so after that, the liver will run out of glycogen and start making glucose from breaking down proteins in the muscles. After a few days of fasting, the body switches to that fat burning mode and starts breaking fat tissue to produce energy through what's called ketone bodies that provide energy to various tissues. And so I wanted to, and before I switch over to talking about diabetes, I wanted to just mention really quickly what we know about fasting in children. As I'm a pediatrician, I'm going to start off by saying that there is no evidence that fasting is harmful for the older child that is healthy and that has a normal weight. When I say normal weight, normal body weight, that is usually determined by the growth chart. So that's when they go to the pediatrician and get plotted against norms for age. So usually families and grandparents do under child's weight. So it's important to keep in mind that, normal might not look, or a thin child might not be underweight on the growth charts. And so there are no studies on Ramadan fasting for children under 10 years of age. For healthy children that are 10 or up, there are very, very limited studies. However, we do know a lot about children who fast for medical reasons, because children who are required to have surgeries, especially elective surgeries, are required to fast before the procedure that requires sedation in order to decrease complications of sedation. And so for those children, there have been multiple studies that looked at various age groups and risk factors. What we know from this body of literature is that very young children, so infants and very young children like toddlers or preschoolers, are at risk for low blood sugars because they have low energy stores and their hormone systems do not kick in as readily as adults and even teens. But there are studies showing that also older children and teens usually tolerate fasting well, and they don't have low blood sugar. So again, I'm going to say that's for the healthy child, for the child that is normal weight, has no other medical conditions. However, if the child has a chronic medical problem, they are underweight, they are on medications, they have medications that they have to take every day, the family should always consult their physician before making a decision to fast. And so we're going to switch over to diabetes and talk about what's specific for individuals with diabetes. In diabetes, this mechanism of insulin shutting off, other hormones kicking in to provide alternate sources of energy is interrupted. These mechanisms are disrupted. Diabetes patients, so type 2 diabetes, they have insulin resistance, so their bodies do not respond very well to insulin. They may have high blood sugar throughout the day, and they have a tendency for their livers to make excessive amounts of sugar. Also for individuals with type 1 diabetes, they tend to, their bodies do not make enough insulin, and so they are on insulin that is injected through a pump or an insulin pen, and this insulin, because we are giving it, cannot be shut off. So when they have low blood sugar, they still have insulin in their bodies that can make their blood sugar exponentially low. The other thing about type 1 diabetes patients is that their fat tissue tends to break down more severely, causing higher levels of ketones and causing metabolic trouble. And so the key risks associated with fasting in people with diabetes in general, type 1 or type 2, are low blood sugar, so that's your hypoglycemia, high blood sugar, which is hyperglycemia, dehydration and thrombosis, and especially in individuals who live with high sugars, that they pee a lot and they lose extra water that is not being replaced during Ramadan, so that puts them at risk for blood clotting. And that what's called diabetic ketoacidosis, which again happens more likely in type 1 diabetes, where they don't have enough insulin and their bodies make extra ketones that cause buildup of acid in their blood and causes metabolic decompensation, can end up being severe. And so there is the American Diabetes Association, and this has been also endorsed by the International Federation for Diabetes. They have come up with risk categories for individuals with diabetes to help both the medical provider, the patient, know or understand how severe or how common the complications are in each risk category. So the very high risk groups, those are individuals that are very high risk for complications. They should probably be advised not to fast. And so those are individuals who had recurrent low blood sugars, had severe episodes, meaning that they had a low blood sugar that somebody had to help them correct. They couldn't help themselves, or had loss of consciousness. Or something like this, and individuals who had low blood sugar, who have low blood sugars that they're not aware of, meaning they lost their awareness of, or what we call hypoglycemia unawareness. Also, poor blood glucose control makes an individual a very high risk for fasting. Individuals who had this DK, diabetic ketoacidosis, or diabetic coma within the last 3 months. Individuals with type 1 diabetes are considered to be very high risk. Individuals who have acute illness, who do intense physical labor because they lose extra fluids through sweating, and then pregnant women with diabetes, and individuals that are on dialysis. The high risk category also associated with high rate of complications with fasting. The moderately controlled blood sugar individuals, individuals who have kidney failure but they're not on dialysis, and those who have advanced cardiovascular disease, those who are living alone and treated with insulin or sulfonylureas, which are medications that make our bodies produce more insulin. So because those individuals are at risk for low blood sugar, and if they're not around somebody that can help them, if they happen to need help, then they shouldn't probably fast. Who have serious medical conditions, old age with ill health, or treatment with medications that might affect awareness of low blood sugar, like some blood pressure medications and others. So it's very important to for those individuals, or for people with diabetes, to have their medications looked at before they decide to fast. Moderate risk individuals are those who are well controlled on certain medications that are short acting, that would stimulate the insulin secretion, and then low risk individuals those who are, and those are probably people who have a low risk of complications or will probably benefit from fasting. So those are individuals with diabetes that is managed only by lifestyle and diet, or they're on metformin or other medicines that rarely cause low blood sugar, and they are otherwise healthy. They don't have other serious medical conditions. And so specifically for type 1 diabetes, type 1 diabetes in a nutshell is a condition that is associated with the body's lack of ability to secrete insulin from the pancreas. Most of the time, they lose all ability to secrete insulin, and so this insulin needs to be replaced. Insulin is the main and the only treatment for type 1 diabetes. It's an autoimmune condition, and it usually starts when an individual is a child or a teenager. So type 1 diabetes is usually managed mainly by insulin, and it is a high-risk condition, like I said earlier, because the body is less able to make hormones that fight off insulin, and they're given insulin, so they can't really shut that off once it's given. They are more prone to making ketones and going into diabetic ketoacidosis. And so now we have, as a medical community, we have many options and very nice and sophisticated technological help for people with diabetes. So individuals with diabetes, especially type 1, especially in children, they have the option of using an insulin pump now, and there are even systems that that will have a feature of automatic adjustment of insulin doses, or turning off insulin when the blood sugar is low. We also have devices called continuous glucose monitors, which are devices that measure the blood glucose every 5 minutes throughout the day and night. So lots of information, prediction of patterns, and very great help in keeping the sugars under control. And so making a decision to fast with type 1 diabetes requires preparation. There are studies that showed that education is a key factor in achieving success with Ramadan fasting in individuals with type 1. And by success, I mean that lower complications plus achieving a higher number of days of completing the fast. So that medical assessment should not happen the first day of Ramadan or the week before Ramadan. It should happen about 2 months or so before. And this is why, is because insulin doses have to be adjusted and the glucose control has to be better before those individuals start fasting, because there is very good evidence that if the glycemic control is poor, the complications are higher. And so the other thing to keep in mind is that they have to have proper supplies for management of blood sugars. And so safe fasting with type 1 diabetes requires frequent monitoring of glucose levels and, when needed, also ketone levels in the blood or the urine. It requires, if an individual is on continuous glucose monitors, it is extremely important to consider using that continuous glucose monitor during fasting, because it will be extremely helpful in predicting glucose excursions and the highs and the lows. Meal prep is also important to do. And so an individual with the diabetes, usually after iftar, they have a high spike in the blood glucose. And so it's important to try to focus on lower carbohydrate meals and maybe avoiding simple carbs, eating more fruits and vegetables to slow down the absorption of the sugars that they're eating. Suhoor is a very important meal and should be eaten as late as possible to delay the onset of the low blood sugars. Adequate fluid intake is important to keep in mind when between sunset and dawn. And the insulin regimen, like I said, not only needs to be changed before Ramadan, but also after fasting a day or two. If there's problems, they need to call their providers and have them address this with insulin dose changes. And so the other very important thing is for these individuals to be prepared to break their fast if needed. And so this is just a suggested frequency of monitoring blood sugars during Ramadan for someone with diabetes in general. And so, as you can see, between the suhoor and iftar, when the individual is fasting, just because they're not eating, that doesn't mean they shouldn't check their blood sugars. It's very important to keep a track of that. Insulin dose adjustment. So we often, for persons with that are on an insulin pump or injections, we make certain adjustments, and usually this adjustment has to do with how their glucose levels are looking before Ramadan, and for us to make an informed decision, and then this is usually revisited a few days after they start fasting. And so same thing with the insulin injections. And so breaking the fast, the general guidelines is that if an individual has a low blood sugar at any time, they should break their fast. The cutoff for adults is 60. For children, it is higher because of their tendency for low blood sugars. And so it can get worse faster. And so it's 70 to 80 for children and teens, depending on the age. So that's usually decided by their provider. Low blood sugar low blood sugar, even if it happens, if it reaches a higher level, but it happens earlier in the day, should be a good reason to break the fast, because it's only expected to get worse. If the blood sugar is over 300, on the other hand, so the other side of things, also a reason to break the fast if an individual is ill or if they have high ketones in the serum or urine. And so what's specific and what's been known about children with type 1 diabetes and what can say successfully fast. Children are considered a very high risk group for fasting when it comes to diabetes. The literature and the studies have shown that children with diabetes, most of the time they do choose to fast. And when they are concerned about having pushback from their providers, they tend to not even mention that they're fasting to their diabetes provider. sometimes they would inform their physician the day before or the day of the first day of Ramadan, and so that usually leads to complications. So what we know about management of type 1 in children during Ramadan is that preparation, again, education, insulin dose adjustments are elements of success. And the main thing, again, is to keep in mind that they should not only consult with their providers, but they should follow the strict guidelines of breaking the fast when needed. And so I think this is all I have. I'll give it over to Dr. Ghalib, and please send us your questions if you have any.
Jazakallah khair. Dr. Mamilly, thank you so much for that content. We will now transition over to Dr. Ghalib's screen. We are already receiving some questions for both of you, so we will address that towards the end of the talk, inshallah. We will start with Dr. Ghalib's talk. Dr. Ghalib finished her medical school education at Baghdad University in Iraq. After graduating, she moved with her husband to New Zealand, where she did her initial training at Auckland Healthcare. Dr. Ghalib finished her endocrinology training in Chicago, Illinois. She then worked at Mary Washington Healthcare in Virginia as a consultant endocrinologist. Dr. Ghalib joined The Ohio State University in 2013. She is the medical director of the pituitary program. She has been working closely with the neurosurgery, radiology, and ENT teams to build a state-of-the-art skull-based and pituitary program at The Ohio State University Wexner Medical Center and the James Comprehensive Cancer Center. She has a special interest in treating acromegaly, Cushing's disease, prolactinomes, and other pituitary disorders. She is a member of the Endocrine Society, the Pituitary Network Association, and the Pituitary Society. Dr. Ghalib, we are very excited to have you, and thank you for joining us today. We will stop sharing Dr. Mamilly's screen, and you'll be able to share yours momentarily.
Perfect.
You can go ahead now.
Yeah, thank you for the kind introduction. Although my bio talk a lot about pituitary, this is not a pituitary talk. So first we're going to talk about why we're talking about diabetes and why we get invited to the literature at Noor community, and thank you for inviting us. And how safe to fast and what are the increased risks, with Dr. Mamilly already mentioned a lot of that. And then what mention adjustment that we need to do. And we're going to touch a little bases about the new epidemic that we're dealing with the COVID and effect on diabetes. So why do we get to talk about it and why we're all here? Just because type 2 diabetes is very common. Now we use, say, 1 in every 11 patients worldwide have diabetes. And a lot of money is spent on diabetes care. And to make the problem bit bigger is 1 in 2 people with diabetes, they don't know even they have diabetes, which makes it even more serious. Then that's not only in older people, it's actually affecting all ages, and 1 in 6 women now in the world, when they get pregnant, they deal with diabetes complication during pregnancy with gestational diabetes. Dr. Mamilly's map world of the Muslim people, I'm showing you the world map of diabetes. And the darker the color in the red is the more diabetic patient. And this is a bit biased just because it just talks about more how many diabetics are in these countries. And obviously United States and China and India are the most populated places in the world. But this is the projection of where we're heading, and unless we do something serious, diabetes is here and to stay, and we just have to learn how to deal with it and how to manage it to decrease the risk of complication. And in general, we always think about diabetes, oh, it's insulin, it's pills and all that. It's really the most important is what the person with diabetes do on a daily basis. I always tell my patient with diabetes is no matter what I'll say, no matter how many prescription I write or do or not, it's really, it's your mission, it's your challenge that you're going to control the diet. I can help, I can give advice, but really diet and exercise is the most important pillars to control diabetes. Medication and insulin definitely can help, but it comes in a backstage what the person can do. Our interest today is to talk about diabetes and Ramadan, and Dr. Mamilly kindly, she did a wonderful job to talk about the physiological effect of diabetes and how it's be affected by fasting and the metabolic effect of fasting in general. A lot of times we tell our patient, or like in general, just talk to your doctor, they can give you advice. But our mission is to try to educate the world and the physicians and the general population here in the United States of what is Ramadan. We physicians typically don't like to take risk. If anything that have a little risk, we say just don't do it. But if a physician know how important Ramadan is, and it's one of the 5 pillars of Islam, and every Muslim is obliged to fast Ramadan if they are able and capable and they're adult. So that takes the decision of who can fast and cannot, make it a bit of a more important decision. So it's all about risk and benefit. And some people did studies that showed how many people do still fast. And the first studies in the United Kingdom, and still half of the people with type 1 diabetes do fast. And about almost 80% of type 2 diabetic fast. Most of them do fast the whole month. Some of them fast have to break the fast in some days of the month. So that comes into who are those people and how can they make a decision and who should make the decision. To be honest, it's the end of the day, it's a personal decision. The person who have the diabetes will make that final decision, can they fast or not. Physicians can help. They can highlight the risk factors and what to look for. The imam can give you the religious point of view, who are exempted, who are not. But at the end of the day, it's your responsibility to make that final decision, and always can adjust the decision depending on the risk. As Dr. Mamilly mentioned, there's a lot of preparation and knowledge that you can acquire to help you make that decision and help you to walk through the journey of fasting during Ramadan safer for diabetic, and to be honest, for all of people who are diabetic or not. Do encourage to talk to your physician, regardless if they are Muslim or not. Mashallah, the awareness of Ramadan is increasing during even literature conferences, and we're all working trying to get more involved and make that happen. So Dr. Mamilly already talked about the high-risk population, the very high, the moderate, and the low risk. So I'm not to repeat it, but if a person with the high risk population wants still to fast, and we've seen the statistics, most people do still, half of type 1 diabetic would like to fast. So linking them with a good qualified diabetes team that can help them, the continuous glucose monitor, be prepared to look for the hypo and hyper and what to do and how to treat them. So I'm going to go over from the type 2 diabetics, that's the majority of adult people have type 2 diabetes. And these are the people are considered low risk, just because the pathophysiology of the disease is slightly different. Although they're all diabetic, type 2 still have insulin. So they have that cushion that it can shut down when their blood sugar goes down. So there are a lot less risk of having hypoglycemia. And most of the medication do not carry that risk. So people who are on oral hypoglycemic agents, and I'm going to go over different groups. This is the green group, the low risk. So for example, metformin, which is the most common medication used, you really don't need to adjust the dose. If you take it once a day, you may want to do it with iftar rather than with suhoor. For agripose, we rarely use this medication, and I'm sorry that I'm going to use brand names rather than the scientific names, just because this is more for everybody. But I'll try to say which group they belong to. So for the Actose or pioglitazone, these are the TZDs. They work by increasing insulin sensitivity. These doses do not need to be adjusted. for sulfonylureas and for insulin, the doses do need to be adjusted. I know Dr. Mamilly talked about the pump setting, but even for fast-acting insulin, the doses will need to be adjusted, and I'll go talk in specifically about the different insulins. For a big group of medication now use these once-weekly injections like Victoza, Trulicity, Ozempic. These work by slowing the gut, so they actually do not cause hypoglycemia, and the dose does not need to be cut down. The only caveat with these medications, probably do not want to start somebody on a GLP in the beginning when they're starting to fast, because it can cause some stomach upset, nauseous feeling. So you really don't want to start a medication. But if you've already been stable on it, you can continue without need of adjustment. The DPP-4, these are medications to adjust our own insulin production and make our own insulin work better, like Januvia, Tradjenta, Emglaza. These do not need to be adjusted. For medications that do need to be adjusted are the sulfonylurea, and these include like glipizide, glyburide, glimepiride. These enhance our pancreas to produce more insulin. So if you imagine, if you still have a lot of insulin on board and your sugar going down, you're not eating, you can run into hypoglycemia. So these medications do need to be cut down by about 20–25%, depend on how well the person is controlled. So those people who are very well controlled when they fast, they do need to cut down on their medications. If they're not well controlled and typically run in the 200s, they may not need to be digested. For SGLT2, these are a newer medication. They work by making the person excrete the sugar in the urine. So they really do not cause hypoglycemia, but because they increase urine output, they can shift people to get dehydrated. So the dose does not need to be adjusted, but you may want to keep better hydration if you are on one of these medications. These like Farxiga, like Jardiance and Vacana. These amazing medication, but they do carry a small risk of hypoglycemia, for dehydration, sorry. For insulin, as Dr. Mamilly said, if you're on a pump, then you can adjust the pump setting. This is a busy slide, but I'm trying to simplify it. So if you're on one of these long-acting insulin, like Lantus, Tresiba, Levemir, if it's once a day insulin dose, you may want to cut it by 15 to 30%, just because they still can cause risk of hypoglycemia. If the dosing of your long-acting insulin is like twice a day, like Levemir, then you may want to take the first dose with iftar, and you may not need to decrease that dose, but then the second dose you want to take it with suhoor, and this one you want to cut by about half, just because it can cause hypoglycemia. For the rapid acting, if you are one of those people who are do carb counting, you may still want to do the same carb counting and cover depending on how much carb you're eating. If you're one of those people who use fast-acting insulin, but you have a fixed dose with every meal, obviously you're going to move the meals to iftar and suhoor, and you may want to cut down the dose, especially of suhoor, so you don't have hypoglycemia when you're fasting. So in summary, most people are safe to fast Ramadan, especially the type 2 diabetics. Type 1 definitely are higher risk, but not impossible to fast Ramadan if you follow Dr. Mamilly's recommendations. And special people that need to pay attention, not that they cannot fast, but they really want to have more attention, is people with kidney problems, risk of dehydration, people with, because make sure they take their medications regularly, they can be shift in fluid and fluid overload or dehydration. Now, what about diabetes and COVID? That's a big topic, and we had a lot of questions when Ramadan started. Hopefully everybody already made in terms with what they can fast or not. But in general, whatever data is emerging, showing that people with diabetes are not at increased risk of contracting the virus as compared to the general population. But unfortunately, if a person already have diabetes and get the virus, they do suffer from more serious complications and increasability. And this is on the American Diabetes Association website, and you can log in and read a lot more. They did an amazing job with updates. So again, if you are a diabetic and you are well controlled, you're well controlled diabetic, that actually decrease the risk of getting the virus and the complication that can happen if you do get the virus. Obviously, if a person have diabetes and have other complications like heart problems and all that, that's of contracting the virus even more serious. We had to deal with that with Ohio State, with all the admissions coming with COVID, is some of the inflammatory process that can happen during the viral infection. And sometimes the intensivists need to use very high doses of steroid to help to decrease the inflammatory response. And both these conditions can lead to a very high levels of sugar, and that can lead to more complication and poor outcome. So having a well-controlled diabetes to start with, inshallah, nobody gets the infection, but getting a well-controlled diabetes decrease the risks of having problems down the road if somebody does get the disease. What about DKA during a COVID infection? Unfortunately, that can happen in any acute illness, as a lot of type 1 do know that. If you have an acute illness, your risk of having DKA increase, and that's the condition when the body gets very dehydrated with high sugar numbers, and that's something that people who do have the disease get monitored very carefully and put on insulin drip if God forbid this happens to them. So this is what I have about the type 2 and diabetes. Dr. Saadi asked me specifically to talk about PCOS, and a lot of people are like, why do we have to talk about PCOS now? PCOS is really very metabolically not very different from type 2 diabetes, although most people do not have diabetes. So I'm just going to highlight a few information about what's the metabolic resistant and obesity, and then I'll move on to describe what is polycystic ovary syndrome and why it's important, what else could it be, how diet can affect PCOS, and why do even bother about PCOS, and how what's the physician role to help people with polycystic ovary syndrome. So I always, when I have resident with me, it's just all tells from the name, polycystic ovarian syndrome. Poly means too many cysts on the ovaries, but that's just the tip of the iceberg of what happens in women with polycystic ovary syndrome. So a lot of people with PCOS have overweight or obese, and unfortunately, it is not an uncommon condition, especially in young people. We say in general about 10% of young childbearing women across the world do have PCOS. So it's not like 1 in 10. So that's not, it can be a very wide spectrum of the disease. And I always tell people it's a syndrome. So the difference between like a specific disease and a syndrome, PCOS, a syndrome means a constellation of multiple things happening at the same time. We think they are related somehow, that they ended up with this wide variety of involvement in the body. So PCOS, if you see the cartoon here on the right, it can affect a lot of factors. It can cause excess hair, can cause weight problems, can cause irregularities, can cause decreased fertility, it can cause disturbing in sleep, in mood, acne. So there is a lot of things that can happen all at the same time. It's a bit difficult to really tell what happens first. Is it the chicken from the egg or the egg from the chicken? Is it a hormone problem in the hypothalamic, in the pituitary, where the pulses of the GnRH start to be messed up, versus it's related to the insulin resistant that can lead to a lot of other metabolic problems. But at the end of the day, we have the syndrome. So the guideline to diagnose, to confirm a person who have PCOS, you have to qualify 2 out of these 3 conditions that I'm going to mention. First one is just the body have too much androgen effect. Androgen is the male hormone. So if the female start to have signs, either clinical by having too much hair growth, acne, which can be signs of too much testosterone, or on the blood test, they have high testosterone. So that's one criteria. If they have signs that they're not ovulating every month, and that can present by either having what we call oligomenorrhea, meaning less frequent periods, or if they don't have high progesterone in the second phase of their cycle. So it's either biochemical or clinical. Or if the third sign is the PCOS, is if they usually have, when do ultrasound, they have multiple little cysts all around the ovaries, and we used to call it pearl on a string. And this is because they cannot ovulate every month, and these small little eggs get trapped in the ovary, leading to this clinical sonographic feature. Clinically, how they can look like, so they have too much hair. Usually it's we have the Glasgow-Coma scale. It's not the Glasgow-Coma scale. We have pictures to see how much hair the person has. Typically, it's the midline hair that matters more. It's in the chin, in the upper chest, in the lower belly, what matters. A lot of people from different racial background can have more hair than others, like the arm hair, the leg hair. That's not as important as the midline hair is more hormone predisposed. Other features is multiple acne. That's hard to treat. They can have what we call male pattern baldness when they start to lose hair from the bifrontal area, and acanthosis, which can be just a sign of insulin resistance. They be darkening of the skin in the skin fold around the neck or the arm, under the arm. So what happens, as I said, it's really hard to tell like what's leading this whole process, but what we know for sure, these women unfortunately have sign of insulin resistance. So typically, insulin is produced when we eat, our body produces insulin so we can lower the sugar. And that's usually once our sugar go down, our insulin level go down, and everybody's happy. And these women, their body does not sense the insulin in a normal way. Their body have to produce a lot more insulin to keep that sugar in the normal range. And we think this high sugar can really affect the ovaries and can make the ovaries fibrose and make the ovaries produce more androgen and testosterone, and that lead to the whole consequence of things. This is just a very simplified version of what a lot of other things that can happen in the body. But the end of the results is that high insulin resistance make the body hang into all the calories, especially carbs, and make the women very hard for them to lose weight. And I always tell people that, and they get very upset, but I tell them, like, if you and your friend go to the gym and you both exercise, probably the person who does not have PCOS can achieve more weight loss and maintain it than a person with PCOS. And people do get upset, but it's good to know how your body, at least you have an explanation why. A lot of people, once they go once and twice and they try and they don't have the results as somebody else does, they just give up and say it's just not working. But if you understand why it's not working, that can lead you to help you is to be smarter and try to find out what can you do to adjust that insulin resistance. And we know that simple carbs, like the sugar, the sweets, the white bread, the pasta, the potatoes, unfortunately, all the good things, but all these are simple carbs. It's just like almost add fuel to the fire and make that insulin level go even up higher, and it can be a vicious circle. We human beings are never a flat line. We are always dynamic. So either we move forward or go backward. And then once we start the cycle of the burning of lowering the insulin levels, lower insulin level make you lose more weight. You lose more weight, you can be able to exercise more and lower the insulin, and then things start rolling in a good way. What else you can load on? I tell my patients, green will be your favorite color in food. White will not be your favorite color. So the vegetables, salads and fruits, I do allow fruit because they do have a lot of other beneficial nutrients. And then obviously protein will be useful. So this is what a person, they can do, what your physician can help you with. So the first line treatment for PCOS is these days contraceptive pills because they continue estrogen and progesterone. So the estrogen progesterone will balance the testosterone and help to decrease the hair, the acne, and can help to regulate the period. Obviously, it's not going to be very useful for a woman trying to get pregnant, though. Spironolactone is a diuretic, but does have an anti-testosterone effect, so it can help with the hair and the acne. Metformin, we used to give everybody metformin. Now the literature really is saying it doesn't help much unless the person does have signs of hyperglycemia, their sugar is starting to be slightly high and abnormal, or they have showing insulin intolerance, then the metformin can have a great effect. If for infertility is the main problem that's going on, then there are some medication like the clomiphene or letrozole that can help to aid. The good news is most women at the end of the day, they can get pregnant because although they don't ovulate every month, but they're not completely don't ovulate. They do ovulate every now and then most time pregnancy is achieved. So this is like why we care and how the doctor can help. So a lot of women, if they don't have the hair or they already got their laser or their electrolysis done and they don't want to have kids, I said, well, I'm done then. I don't have to worry about PCOS. Unfortunately, PCOS is, remember, it's a condition, it's a whole life thing. So affect the whole body beyond just the fertility and the cosmetic effect of it. The high unopposed estrogen can cause endometrial cancer, especially in older women. It can have a lot of mood just because of the body image and the weight and the struggle can cause a lot of depression, anxiety. Especially the obese PCOS women can have obstructive sleep apnea. If not, and especially as we get older, our risk of diabetes increase anyway, so they can become full-blown diabetic, they can have heart problems. So it's not just a one-type thing. It's something that they need to live with it and know how to deal with it to decrease all these risk factors, and a physician need to monitor these things. So, I mean, I don't know if we have time is to talk about how fasting and how diabetes can affect with that. I think I'll stop, and then if somebody have a question, I can answer it.
Thank you so much for your insightful content, Dr. Ghalib. We do have a few questions in the Q&A box for you both. I saw Dr. Mamilly has already started answering some. Thank you for doing that. We do have a question here that may be addressed to both of you. The question asks, my OBGYN told me I cannot fast because I had gestational diabetes. Shouldn't fasting help my diabetes?
So I don't know, you want to answer that, Lena?
Okay.
I can answer it. So yeah. So especially this is like an older woman. So like an adult. I'm sorry, an adult woman. So it's, as I said, we physicians do not like to take risk. We are physicians. It's just easier just to take the easiest path. And if I don't know what diabetes is, and I see that I am going to not eat and not drink, and I get dehydrated, then probably it's just easier to say don't fast. Same thing with pregnant women, with breastfeeding, with all type 2 diabetic. It's just easier to say don't fast. But to be honest, I'm not sure if this is the best, easiest way. It's just you need to find out what's your risk factors. To me, if you do have gestational diabetes, you probably have pre-diabetes and you do have insulin resistant, got exacerbated during pregnancy. That's why the person had gestational diabetes. And fasting in a healthy way, monitoring diet, monitoring intake is probably going to be useful rather than harmful.
Thank you for sharing your answer. We have another question here from Sundas asking if insulin can cause kidney failure.
I'm happy to answer this question. The short answer is no. And the long answer is that this is actually a misconception. It's a very important one. We get it even in the pediatric world, especially in children who are diagnosed with type 2 diabetes, which unfortunately more and more of. And the problem is usually when an individual, especially in the adult world, it's different in children because as soon as they are diagnosed with type 2 or type 1 diabetes, they are placed on insulin simply because of the fact that we don't really have FDA-approved medications that can be taken orally for a child with type 2 diabetes. However, in an adult with type 2 diabetes, in order for them to be for their sugar to be high enough to be and so on, or they have other complications, they will have had diabetes for long enough that their kidneys are already affected. And so the breaking point where insulin is required for their treatment, they notice that also they start to have the end organ associated with diabetes. It's a very important fact to know that many individuals with especially adults, when they are diagnosed with diabetes, usually they have lived with the disease for a very long period, for years and years. And so that disease has been around, it has been affecting their organs, it just hasn't been brought up to the medical attention and hasn't been diagnosed. No, insulin does not cause kidney failure. I don't know if Dr. Ghalib has anything to add.
Yeah, I mean, we used to get that. Now the general population is more aware of that, but we used to, like people, once we put them on insulin, said, no, I remember my grandma, actually when they put on insulin, that's when she had her leg amputated. And it's, as Dr. Mamilly said, it's just because we were probably not using insulin early enough, and we save it until the person is very sick, and that's what we use in the hospital when person have multiple complications. So it's not really the insulin that caused the leg to be amputated, is that she was so sick that they had to put her on insulin. Same thing, I still get that with metformin. So metformin is the most common medication we use, but unfortunately, if somebody have kidney problems, if their GRF is below a certain point, we cannot use it anymore because they increase the risk of lactic acidosis. And a lot of people, when they say, oh, you have kidney problems, we can't use metformin, they just assume that the metformin caused their kidney problems, and their relatives would not want to use metformin because that problem. This is still exists, and we still get that a lot. It's just, again, we're not using the metformin because they already started to have some complication, and then we're stopping it.
Thank you, doctors. Another question we have two questions related to keto diet, actually. One, Dr. Mamilly addressed in the private Q&A, if you'd like to address it live, asking if keto diet is safe for children. Another question we have that may be relevant to both of you, someone asks if they can follow keto diet and fast at the same time.
Okay, so in the children, I typed up my answer. The short answer is that we don't know how safe it is for children to follow the ketogenic diet. There have been no studies looking into this diet, and I can tell you that in the pediatric population, the main scenario in which a physician might suggest a ketogenic diet is basically for children with epilepsy. Sometimes they resort to that when medications don't work. Now, my two main concerns about the ketogenic diet is one, related to the physical aspect of that diet, because this diet is known to cause metabolic changes, it's known to cause in body composition, and how safe this is for a child that needs to have macronutrients, including carbohydrates, is unknown. The second thing is how this diet affects cognition and affects children's alertness, academic performance. And I say this because if they are using it for children who have seizures and to suppress those seizures, what can we assume that it is doing to a healthy brain? And so I would say be very cautious, probably refrain from using this diet before adolescent years.
So for adult, it's slightly different. So for adult, it's a love-hate relation with keto diet. For sure, we know keto diet works for lowering weight for a short term. So it does work if people can use it to lose weight. So that's a simple answer. The more complex, and to link it with Ramadan, I mean, that's the 16-hour fast is something that are popular now, not just with Ramadan, not just with Muslim people. As Dr. Mamilly mentioned, the 2-5 is fasting 2 days and break your fast for 5 days. So that's one fashion is happening now. And the other fashion is, I'm still calling it fashion, but like it's a lot of people are doing it, is people fast for 16 hours and eat for 8 hours. Typically they eat from noon till 8 p.m. and then they don't eat anything till the next day noon. And that has showed to cause micro keto. That's how it works. It's just like, remember when Dr. Mamilly mentioned, once your glycogen storage get used, our bodies start to break down fat to produce energy because we have to survive. And the byproduct of doing that is ketones. And making that fat like that, making the body make ketones is we're switching our metabolic whole scheme from a save mode to a burning mode. And we click the metabolic panel back and forth. And that's how ketones work is after you finish your glycogen is once you start to burn the fat, and that's why you lose the weight with the keto diet. In Ramadan, we all do little keto, and that's what we're doing. At the end, if we check our ketone bodies, probably by just before iftar, probably will have all little ketones in our body. The question is how much is safe and how much you can push the limit. You've heard me and Dr. Mamilly talking about DKA. What DKA is diabetic ketoacidosis, is these ketones are acids. And in the end of the day, if you build too much acid in your body, your whole metabolism can be affected significantly. You can feel nauseous, you start to vomit, and you can get very dehydrated and can be life-threatening. Most people when they do keto diets, they don't go that far because they keep well hydrated, they drink all that water to wash these ketones so they don't get to a level of DKA. Now, if you're fasting and do keto diet, probably people can do it, but you're really pushing the envelope, and you can tip to a DKA it can happen. So the deal is if you're doing keto diet, you're supposed to hydrate a lot to wash those ketones from your body.
Thank you for your answers. Let's wrap up with two last questions. You can both answer one each or have an input on both. One asks if PCOS can be cured. I know Dr. Ghalib addressed PCOS treatments, but the question asking if it can be cured entirely. And another question asking if type 1 diabetes can be cured.
So I'll take the first one and you take the second one. So it's the same question if you ask me if can diabetes be cured. And before we used to say no, until people start to have bariatric surgery and lose a lot of weight. And actually we start seeing the type 2 diabetes completely goes away and get cured. So and with PCOS, it's almost like it's better than type 2 diabetes because you haven't reached to the non going back stage. You still have only insulin resistant and you're not diabetic even yet. So it can't be controlled. If you lose the excess weight, if you decrease that insulin resistance, yes, people can start to have regular period and the acne gets better. Now the hair is a bit hard if you call it cured or not. The hair, once the terminal hair did grow, they don't go away. They're still there. They can get thinner, but they don't go away. Same thing with the acanthosis. They can be lighter, but they don't go away. But the metabolic profile, the ovulation, the fertility, and all that, yes, it can, as long as they're controlling the weight, controlling the diet, and controlling the insulin resistance.
Right. In regards to type 1 diabetes, we don't have a cure yet. There has been a lot of studies. There continues to be a lot of studies ongoing, both to try to prevent type 1 diabetes from evolving in the individual who is at genetic risk or immunologic risk, meaning that they have antibodies, they have the markers of autoimmunity, but they haven't developed the hyperglycemia yet. There's also studies that have been done and still go to try to maybe honeymoon phase, that is called, when you have a little bit of partial remission, a little bit of restoration of the body's ability to produce a little bit of insulin after the diagnosis has been made. Usually you have a grace period of about a few weeks to a few months where that could still, insulin ability still can be saved. There have been no agents that have been proven to provide that sort of cure. Islet cell transplantation, so putting back or transplanting cells that produce insulin, is also underway. It's under studies with various success rates. Nothing has been, or no studies have come out that have earth-shattering results that can be called a cure yet. We have made, as a medical community and industry, we have made strides, and they continue to make leaps in terms of perfecting diabetes management technology, insulin delivery, talk between glucose monitoring and insulin, the automatic adjustment of insulin delivery, and so on. So in this area, we have made a lot more development than we have in terms of a cure. There is no cure yet, but we're very hopeful that it might happen in the next couple of decades.
Wonderful. Jazakumullah khair both for sharing your time and expertise. We really appreciate you taking the time to join this webinar and take part of it. I would once again like to thank all of our attendees for joining as well. Before we wrap up, please remember to share some of your charity during this month with our Noor Islamic Cultural Center to sustain our mosque and sustain our programs that are provided now virtually. For any questions or suggestions, you can email education@noodohio.org. And a reminder that this webinar will be uploaded to our YouTube channel as well and will be available to everyone after this live webinar is done. And once again, thank you to our speakers. Thank you to all our attendees. Have a blessed rest of your Ramadan and an early Eid Mubarak. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you for the invitation. Assalamu alaikum.